going to introduce. The first will be Semi-1 from the Raisi Hospital from Tunisia.
Good afternoon, everybody. It's actually a pleasure for me to be among you here today to talk about sexual disorders in female patients with bipolar I disorder. So I have no conflicts of interest to declare. I come from this country, Tunisia. So you can see here in green, Tunisia is in North Africa, not very far indeed from Greece. So this is the hospital I work at, Raisi Hospital in Manouba in Tunisia. So this is the only psychiatric hospital in the country. Of course, there are other psychiatric departments in general hospitals in other cities throughout the country, but this is the only psychiatric hospital serving more than 4 million people with more than 105,000 consultations per year and more than 6,000 admissions per year. So this is where the study took place. So after this introduction, we are going to talk about our topic today, about sexual impairment in female patients with bipolar disorder. So you all know that sexual impairment is very common in the general population, concerning up to 40–45% of adult women and up to 30% of adult men. Sexual impairment is even more common in psychiatric patients with a high prevalence across all diagnoses, particularly in mood disorders. So sexual dysfunction is common in patients with bipolar disorder, but it's also very important to consider. Very important to consider because you all know that decreased sexual well-being negatively affects the level of happiness in all aspects of life. This is true for the general population, but this specifically applies to mental patients, and this was demonstrated among them. You also know that sexual side effects of psychotropic drugs are closely related to poor adherence, and then also the alteration of sexual desire, arousal, or the ability to have an orgasm has been associated with suicidal behavior in bipolar patients. So, our bipolar patients having symptoms of sexual dysfunction have a decreased well-being, so they have poor adherence to the treatment we prescribe, and they are more prone to suicidal behavior. So although common and important, this topic is really largely understudied. In fact, what do we really know about sexual function in patients with bipolar disorder? Well, all we know and all we're talking about is possibly hazardous hypersexuality during manic or hypomanic episodes. But that's all, or almost all we're talking about. What else? Well, we have very few studies. And what about females? Well, we have very, very few studies about the sexuality of female bipolar patients. And that's why we wanted to have a closer look at this topic. We aimed to examine sexual disorders in female patients with bipolar I disorder and to scrutinize the associated social demographic and clinical factors. And that's why we carried out a cross-sectional descriptive and analytic study over a period of 5 months involving all followed-up female patients aged between 20 and 60, diagnosed with type 1 bipolar disorder with the criteria of the DSM-4, and who have been euthymic for at least 6 months at study entry. We did not include patients with a comorbid axis 1 or axis 2 disorder. We did not include patients with a comorbid medical condition that might affect sexual functioning. patients without a partner were not included because the scale we used to require the partner, and then pregnancy, postpartum were also non-inclusion criteria, and obviously patients who did not consent to participate in the study were not included. So this is the scale we used, so the Arabic version of the Female Sexual Function Inventory, or the FSFI. So this is a brief questionnaire measure of sexual functioning in women during the last 4 weeks. And it explores 6 different domains: desire, arousal, lubrication, orgasm, satisfaction, and pain. So of course we use the validated Arabic version in form of an auto questionnaire. So what were the characteristics of our population? We had 30 patients with a mean age of about 40, so most of our patients were married, and about 2/3 were jobless. So the mean age of onset was about 28, with a standard deviation of about 6 years. The mean duration of illness was about 12 years, and our patients had more manic episodes, that's to say 4.7 per patient, than depressive or mixed episodes. So about 1/2 had at least one episode with psychotic features. What about the treatment our patients were receiving? So all of our patients were on mood stabilizer, so most were on valproic acid, and about 2/3 were receiving an antipsychotic treatment. So 2/3 of patients on antipsychotics received an atypical agent, while about 1/3 had a conventional drug. So about 2/3 of our patients were on benzodiazepines, and no patient was on an antidepressant treatment. So here are the FSFI scores in our population. So this table shows the different scores we had in our population, along with the threshold set by Weigel. And as you can see here, our patients had significantly low scores in all FSFI domains, and of course lower overall FSFI score, so lower than the threshold set by Weigel. So our patients had a low overall FSFI score. So this is not really a new finding. You all know that impaired sexual function is common yet underestimated in patients with bipolar disorder of both genders. Well, it's really underestimated, and that's the main problem. Underestimated first because patients rarely get into sexuality spontaneously, so we have to ask them, and routine assessment of sexual functioning is rarely performed, although of a crucial importance. So we have very few studies about female sexuality in bipolar disorder, but the first studies showed no real difference between females with bipolar disorder and the general population. But most of these studies were, let's say, flawed from a methodological point of view, and they basically relied on empirical data. So recent studies emphasize altered sexual functioning in female patients with bipolar disorder, both in bipolar 1 and bipolar 2 patients. However, and this is the main difference with our study, most studies assessed sexuality regardless of mood state. So we only selected patients who were euthymic, but most other studies assessed patients regardless of their mood state, even though we all know that mood episodes can influence sexual functioning. So our patients had an overall low FSFI score, but they also had low scores in the different domains, and we're going to talk about these different domains very briefly. So our patients had a decreased sexual desire, and it's consistent with the data from other similar studies, since sexual desire is known to be decreased in bipolar patients from both genders, and females might be more affected than males in this regard. Bipolar 2 patients might be more affected than bipolar 1 patients. And we have a Tunisian study that involved patients with schizophrenia and patients with bipolar disorder from both genders, so this is not specific to the female gender, and this study found a rather high prevalence of sexual desire disorder in patients with bipolar disorder, so about 29%, but patients with bipolar disorder did better than patients with schizophrenia. So what about arousal and lubrication? So our patients had problems with, so they had low scores in both domains, arousal and lubrication. So this is consistent with other studies. In the same Tunisian study we cited earlier, arousal disorder was found in about 35% of bipolar patients from both genders. So it was less common than in patients with schizophrenia. To our knowledge, no previous study assessed vaginal lubrication in euthymic bipolar patients. However, we have few data about lubrication. So we know that impaired lubrication is common in psychiatric patients in general, and in particular in patients with a mood disorder. And we have a study that showed that up to 50% of women with depression reported difficulties in obtaining satisfactory lubrication. So what about orgasm? So the fourth domain that FSFI explored. So our study showed altered orgasmic function in female bipolar patient. This finding was not consistent with the other studies, showing no significant alteration in the orgasmic function in bipolar 1 or bipolar 2 patients. So why this discrepancy between the result of our study and the results of other similar studies? Well, maybe because of the difference in age. The mean age in our study was higher than in other studies, and probably also because of the high proportion of patients on antipsychotics and on benzodiazepines, which are agents which have been associated with orgasmic alterations. So what about satisfaction? We all know that sexuality is all about satisfaction. This is probably the main or the most important component of the FSFI score. So our patients were not that satisfied, so their satisfaction scores were lower than the threshold set by Weigel, and this was consistent with many other studies that showed no or poor satisfaction in almost 2/3 of patients from both genders with a severe chronic psychotic disorder, including bipolar disorder, but also schizophrenia and schizoaffective disorder, and sexual satisfaction would be more impaired in women than in men with bipolar disorder. And then we have another study from Turkey that showed a higher dissatisfaction score in bipolar women than in controls. But other studies showed the contrary, since there are other studies which showed no significant difference in sexual satisfaction between bipolar patients and healthy controls. And the same Tunisian study we've cited earlier showed a very low prevalence of dissatisfaction. So only 6.6% of bipolar patients were not satisfied with their sexual life. So again, why this discrepancy? So probably because of differences in inclusion-exclusion criteria among studies, as well as because of distinct measuring tools. So what about pain? So we explored the sexual desire, arousal, lubrication, satisfaction, orgasm and satisfaction. Now we are moving to pain. So according to our study, patients with female patients with bipolar disorder exhibit increased pain during or after intercourse. They have scores which are lower than the threshold. So this is not consistent with other studies, showing no significant difference with healthy controls. Again, the difference might be due to the mean age in our study and to the high proportion of patients on antipsychotics. So then we tried to see what or which clinical features were associated with low FSFI scores. And here, as you can see, we only found one significant correlation between the number of depressive episodes and vaginal lubrication. It was an inverse and rather weak association. So the higher the number of depressive episodes, the lower the lubrication score. So in the literature, there are very, very few studies which try to search for links between the clinical features of bipolar disorder and sexual functioning. We only found one study that simply compared females with bipolar 1 and females with bipolar 2 patients. And this study found that bipolar 2 females had a lower implicit sexual interest, a lower desired frequency of intercourse, and a lower occurrence of repeated sexual intercourse than their bipolar 1 counterparts. Then we tried to compare patients who had psychotic features during their episodes with patients who had no psychotic features during episodes. And we found that psychotic features were associated, significantly associated, with lower overall, with a lower overall FSFI score, but specifically with lower lubrication and orgasm scores. So this might be due, at least partly, to a more common prescription of antipsychotics in patients with psychotic symptoms. So what were the effects of the medication we prescribed on the FSFI scores? So as you can see here, the FSFI scores in our population did not differ significantly according to the type of mood stabilizer used, and did not differ between patients on or without benzodiazepines. However, the use of antipsychotics was associated with significantly lower lubrication and orgasm scores, as you can see here. So, indeed, this result might be due to antipsychotics being more commonly prescribed in severe cases. So, this might be also the effect of the disease itself. We are prescribing antipsychotics to the patients with the most severe cases, and then maybe and probably also the possible effects of antipsychotics on sexual function, that is to say the iatrogenous effects. Indeed, antipsychotics are known to be commonly associated with sexual dysfunction in females, and you can see here that the figures are very, very high. Sometimes we found prevalence of up to 96% of sexual dysfunction in females on antipsychotics, even though all these studies involved patients with schizophrenia. So antipsychotics might reduce sexual desire, dampen arousal, alter the vaginal lubrication, and inhibit orgasm. Conventional antipsychotics seem to be more likely to induce such effects than atypical drugs. However, amisulpride and risperidone are two atypical drugs that seem to be very commonly associated with sexual disorders. So now what about mood stabilizers? Well, in our study we found no differences in FSFI scores according to the type of mood stabilizer used. This might be due to the low number of patients on a mood stabilizer other than valproic acid. So that may be the cause of the absence of a statistical significance. However, most mood stabilizers, with the exception of lamotrigine, were associated with sexual side effects in females, even though most studies involved patients with epilepsy rather than with bipolar disorder. So valproic acid has been associated with decreased desire, so altered orgasm, with menstrual disturbances, as well as with polycystic ovaries. Valproic acid decreases the synthesis of sexual hormones binding globulin, thus increasing the active testosterone. Carbamazepine seems to be the most stabilizer, most associated with sexual dysfunction. So carbamazepine, being an enzyme inducer, increases the synthesis of sexual hormone binding globulin, increases the metabolism of sex hormones, thus decreasing the levels of active testosterone. Carbamazepine decreases desire and alters orgasm. What about lithium? Well, we have very few data about lithium, but some authors suggest that lithium might induce decreased desire and might dampen arousal in female patients. So finally, we are going to see the effects of benzodiazepines. So in our study, the use of benzodiazepines had no effect on FSFI scores. In fact, that might be due to the low proportion of patients not on benzodiazepines, because 2/3 of our patients were receiving benzodiazepine. So benzodiazepines have been associated with decreased desire and orgasm, but most studies about the topic are rather outdated. So this study allowed us to have a snapshot of the patient's sexuality at a given time, especially given the cross-sectional nature of the study. But the snapshot, so it's certainly important to have a snapshot, but it's not necessarily representative of the sexuality of our patients throughout the course of their disease. And then the naturalistic setting of the study allowed us to describe sexual functioning in usual circumstances. We included all patients, so regardless of the medication they use, and we did not alter any medication. So this allowed us to see the real things, so the usual circumstances and the usual patients we see in our everyday practice. However, the naturalistic setting did not allow us to make any difference between the effects of the disease itself and the effects of the prescribed drugs. So to conclude, we can say that even when euthymic, even during those said free intervals, and you all know that they are not really that free, female patients with bipolar disorder exhibit symptoms of sexual dysfunction, and the role of the disease itself is very likely, but one shall not forget the role of the medication, especially the role of antipsychotics. And then this topic is very interesting, very important, but remains largely unstudied. So further studies are really paramount in order to scrutinize the effects of mood episodes, the effects of comorbid psychiatric and medical disorders, and the effects of each medication. And thank you for your attention. Here is a QR code for those who want to download this slideshow, so you can use it to download this slideshow. Thank you for your attention.
Thank you very much, Semi. Maybe do you have any questions or any comments for Sami?
I have one. In your study, did you see any differences across the atypical antipsychotics and their ability to cause sexual dysfunction?
In our study, we did not see any difference between conventional and atypical drugs. Well, I did not present this because of the time limit, but we did not find any difference. But this might also be due to the fact we combined all atypical drugs together, and many of our patients were on risperidone. So that might be also a flaw.
What do you speculate is going on here? Do you think it's the drugs are blunting the pleasurable response, producing anhedonia?
I think there are many different mechanisms underlying so the effects of the antipsychotics in particular. So there's the hyperprolactinemia, of course, which induces a hypogonadism. And thus alters mainly desire. So it decreases desire, and it decreases arousal and lubrication because of the hypogonadism. But there are also there's also the anti-D2 effect. We know that dopamine is an active component, or is associated with desire and with pleasure in particular, and during orgasm. So there's normally a rise in dopamine levels in nucleus accumbens. So maybe also so the anti-D2 effects prevents that rise in dopamine levels. That might also explain why conventional drugs might be more prone to induce such side effects. And then there's also the serotoninergic system, which is involved. So it might also contribute to these effects.
Thank you.
Great question. Thanks for the presentation. In terms of treatment-wise, would you, what sounds a lot of organic factors in causing the sexual impairment? So would you suggest more psychosexual counseling or more medication, discussing with endocrinologists or that kind of?
The problem here is that we have very, very few data about the topic to know which is or what's the role, the exact role of each component. So we know that for sure medication interferes, that bipolar disorder itself interferes, especially because of residual symptoms, of mood symptoms, even during free intervals. But the problem is that we cannot say for sure what's the weight of each of these, let's say, factors. And I think that maybe one factor might be very important in one patient, but not in another patient. And according to the respective weights or the respective importance of each factor, I think we can have, let's say, therapeutic intervention based on, so it depends, I think, on the cause. For instance, in patients who are on antipsychotics, so we can, for instance, try to reduce the dosage, or to quit the antipsychotic drug, or to replace it, to substitute it with another drug which might be less associated with so these disorders, or with sexual disorders. Certainly, I mean, psychotherapy can play a role, especially for sexual disorders that are linked to the mood, or to psychopathological, let's say, symptoms. So, for instance, for patients with residual symptoms or with comorbid anxiety disorders, psychotherapy is certainly very beneficial.
Thank you very much. Do you have any more questions? Okay, I think that this theme is very interesting because the female sexuality is very complex. When we research about men, we only have we only pay attention in erectile function and satisfaction. But in women, we have we take other outcomes, no? So it's very interesting. Thank you very much.
The problem is that female sexuality is not really visible, very visible. And that's why I think that studies about female sexuality in general are rather scarce.
There is more stigma.
There
is more stigma about the
yes.
sexual dysfunction in females, especially in our country.
When we research in men, we have subgroups of not married men and homosexual men. Maybe with women who must be the same thing. Thank you very much.